two-sentence introduction. As you heard before, my name is Michael Krausz. I'm a German Canadian. I worked in until 15 years ago. I worked in Germany, and since then I'm in Vancouver as a leadership chair for addiction research. And I'm passionate about building better, more effective healthcare systems for the most vulnerable. Jing, you want to continue and then name the next one to introduce?
Sure. Hi, Michael. Hi, Alicia. My name is Jing Lian. I'm in Windsor, Ontario, Canada. I'm a Chinese Canadian. So I'm a clinical care coordinator working under the provincial government Ministry of Health, but with a CMHA health center here. And I'm working on my medical license to become a psychiatrist. Happy to be here. So I can see Jonathan.
Can you hear me?
Yeah.
My name is Jonathan Ikabuchi. I work as a substance use clinician for Interior Health in Kamloops, British Columbia. I have a student, a Bachelor of Social Work student with me today, Megan Daglish. And
hi, Megan.
We're just interested in this whole conference because with COVID, we've had to move a lot of our frontline services virtual. Thank you.
Thanks a lot. Could you suggest the next one?
I can't see the screen, so I guess it's Jake.
Okay, Hazel, would you want to, Hazel and Don, would you go introduce yourself?
Yes. Good morning, everyone. My name is Hazel Meredith, and with me I've got Don Tufford. I'm the CEO for Mental Health Recovery Partners. We've rebranded from the old BCSS Victoria to Mental Health Recovery Partners, servicing a wider variety, specializing in peer support and counseling and recovery perspectives. And Don Tufford is a retired psychiatric nurse he was with the early psychosis team. And I'm also the board president for the Schizophrenia Society of Canada.
Wow. Long list of titles. Could you?
And I love this conference. I've been many years. It's awesome.
Thank you. Could you suggest the next one to introduce himself or herself? Lloyd, could you introduce yourself?
Yeah, I sure can. My name is Lloyd Main. I live in the sunny Okanagan. I work with Métis Nation BC in the addiction and harm reduction division. And on a side note, my oldest son is just completed his residency in addictions for physicians. So
excellent.
So he's one of the young ones you were talking about.
Yeah. Yeah, you should tell him next time to come over.
Unfortunately, he's working today.
Oh. Okay, then Jeanne, can you introduce yourself?
Are you looking at me, Michael?
Yes.
Okay, great, thanks. Hello, I'm Jen Kilty-Friezan. I'm the Director of Addiction Services at Addictions and Mental Health, Hastings, Prince Edward. So we're about 2 hours outside of Toronto in a rural area. Rural being, it's about 7,000 kilometers top to bottom, and about 150,000 people in it. So okay. We work out of the major city there, which is Belleville. But as you can imagine, we've got lots of challenges that have come, like Jonathan has said, through COVID. How do we flex our services in areas where there is no such thing as internet yet? So it's been an interesting couple of years, to say the least.
But then you exactly know what I'm talking about, actually.
Oh yeah.
Deborah, you want to introduce yourself?
Sure. Hi, everybody. I am located in Ontario, in the Waterloo region of Ontario. I work with an agency called House of Friendship, and we are a pretty comprehensive service provider. Our addiction services portfolios cover RAM clinics, community withdrawal support services, community-based intensive treatment programs, residential programs, individual counseling. And we have had to adapt all of our services over the last couple of years. I'm currently managing our intensive day treatment program, which is being offered exclusively virtual at this time. And so we've adapted our entire program to be that way. And all of our clinicians are working remote. We are still, of course, encountering challenges around what does it look like to deliver in-person services versus virtual, and who is falling through the cracks versus who is actually accessing services better as a result of remote service. So lots of questions.
Lots of questions. Exactly, you are in the right place. Dita, would you be so kind?
Yeah, hi, my name is Dita, and I'm calling in from the unceded traditional ancestral territory of the Secwepemc Nation, which is Kamloops, British Columbia. And I come to the work as a social worker and a counselor typically, but this year I'm a practice lead in substance use services. And I'm supporting, right now, one of the things that I'm supporting is the development of an outpatient withdrawal management program. And so lots of talk, there's a physician component, a prescriber component that will be virtual, because we struggle in the interior region to have local prescribers to support a program like outpatient withdrawal. So I'm pretty excited to just see because the nursing scope will be more in person, partially virtual, but the physician scope will be virtual. So a talk like today, and this whole conference just really resonates with me in the work that I support.
Pleasure. Theresa, would you like to introduce yourself?
Yes, hi. I'm Theresa Stukowski. I'm a counselor with Surrey Substance Use Services in British Columbia. So I'm one of the counselors here, but we also have both the counseling, we have an OAT clinic, and we have a clinic for the Southeast Asian population. And because with COVID, we've had to use both in-person and virtual, and just sort of some of the challenges with that, where like our groups, for instance, are mixed. So we have in-person and virtual, and it almost feels like a 10-ring circus sometimes, just trying to do everything at once and trying to coordinate that and not feel like somebody's left out. So just any information regarding how better to integrate virtual into our services would be appreciated.
Yeah, that's a challenge, absolutely.
Yeah.
Olga, could you continue?
Yeah, my name is Olga Bedrikova. I'm working for Polycultural Immigrant Community Services in Toronto, Ontario, and I'm working with addiction among newcomers. Thank you.
Thank you. Welcome, Olga. Tiffany, could you continue just a few words?
Hi, I'm Tiffany. I work with Anotic Healing Lodge and Learning Center. I am the outreach worker for youth with addictions and mental health issues in Aurelia, and we work with the Simcoe County District. And I'm quite intrigued on the discussion that's going to occur today, the best way to support our clients virtually. Thank you.
Thank you very much, Tiffany. Melinda, you want to go home?
Sure, absolutely. Okay, so I'm Melinda. I'm the program manager at Senior Persons Living Connected, which is a community support service agency out in Scarborough, which is a suburb in Toronto, Ontario. And we have our addiction supportive housing, as well as some case management and counseling, working with the older adult population. And I think specifically throughout this pandemic, like many of the other guests have said, we've had to pivot to virtual quite quickly. And so joining this conference to see, what else we could do better.
Wonderful, thank you.
Thank you.
Omar, would you go next? Omar. Hello. Okay. Rita, could you go next then?
Hi, everyone. I'm Rita, and I'm currently a policy analyst with Health Canada's opioid response team. And right now I'm working on a file that's basically analyzing how effective virtual support services have been for substance use in replacing in-person services.
Rita, you're welcome to build on our experience, and happy to help you with your difficult job.
Perfect, thank you.
Stella, could you introduce yourself?
Hi, sorry, it just took me a minute. Hi, yeah, my name is Stella. I'm a social worker with BC Mental Health and Substance Use, working with the community transition team out of Nanaimo Correctional Center and Vancouver Island Regional Correctional Center on the island. Thank you.
Fantastic. Shauna, would you go next?
Hi there, I'm Shauna. I'm currently the territorial lead for addictions and recovery in mental health and community wellness for Northwest Territories Health and Social Services Authority. I'm up in Yellowknife on Chief Drag East Territory. So working on a lot of projects that's really relevant to all of this, including medical detox, our opioid enhancement project. And I've spent the last few years as the opioid program case manager for the territories, where we had to really also rapidly pivot to a lot of virtual care. So we're providing services out of Yellowknife to a number of different small fly-in communities through the territory, and just looking for ways to improve our services with that.
I can imagine. Welcome, Shauna. Rachel, do you want to go next?
Sure. Hi there, Rich Johnson. I'm a policy advisor in the addiction mental health branch of Alberta Health. So we fund a variety of different harm reduction treatment services, and just here to, kind of keep apprised of all the emerging and innovative services out there.
Welcome, Rachel. Thank you very much for participating. Jennifer, what could you introduce yourself?
Hi everyone, Jen Comey-Brown, harm reduction coordinator with Fraser Health. Just excited to be here today and learn what's going on.
Thank you. Frank, you would like to go next? Frank is obviously still muted. Tara, would you like to go on? Okay. Anybody who wants to introduce? So did I miss anybody, or shall we move on? Richard, you want to say a word? Guess our dear participants not finding the unmute button. Okay, Richard? Okay. Then let's start the conversation. I suggest there were some questions I would pick up from the discussion after the keynote. Just wanted to say, if you are interested to get any additional material, if you are interested to get the slides or whatever, you could either communicate with Alicia, or you could send it to the organizers, and we're happy to share the materials to you. So that kind of, sorry very much for putting my personal headshot too much into the interfering with the slides. It had everything, it has to happen so quickly. So what I thought that is an opportunity in this very broad scale group is to discuss the details of virtual care. And I really invite you to interrupt me and to have conversation on the different topics along the slides. And I'm using the same slides I showed, but with a little bit, with no headshot and with a little bit more time to go through the things, to go to the components, to go through the way we're envisioning virtual substitution clinics to work. And as I heard from you, you're already kind of confronted with the task to reorganize your service to a certain degree on a virtual level. I think you exactly know what is needed, and whether you work in rehabilitation, in detox, or in methadone, or in Suboxone, or whatever old treatment, that you are really need to build virtual components, which is really what it is about. So I will now share my screen, and will hope everybody can see this. And I give a really a short summary about the different questions. And this is a slide deck we are also sharing with you so that you can have a closer look yourself. Okay, I'm not going through the introduction again. We did that. So right now there are different components in our response. So in the overdose crisis, safe injection is a big one. OAT treatment is overall probably the biggest treatment approach internationally. So there are far more people going into OAT treatment than right now going into abstinence focused programs in rehabilitation or detox. And everybody knows exactly that, for instance, if you don't have a continuum of care and you detox people, then the risk of, if there is what we call relapse, or if you use again, you underestimate your opiate tolerance, and the risk of then dying of an overdose is probably just 60–70% higher than among continuous users, which is also the case, for instance, if you're released from prison, or if you, after a time of abstinence, you restart using. Okay, so the reason of reconsidering the model of care is really to integrate the different needs, have a better comprehensive understanding of needs, and also really starting about a model of substitution care. And integration of web-based resources and physical resources is the goal. There will be, in the future, I think you can be 100% sure, there will be both of them. There will be still physical resources. We meet people, you talk to people personally, but there will be also a growing amount of online resources. And you have some tools in addition to what you probably dreamed of so far on hand, if everything kind of is going as planned, which are allowing you for all kinds of early intervention approaches. So, and that could lead to something like risk prediction. The reason we are working from this paradigm of risk prediction is we don't want to make it stigmatizing at all. We want to really work from the framework of risk prediction and risk management, because it's the least stigmatizing. It's including all the different conditions, and it is also including all the stuff which is happening in the prevention domain and in the early intervention domain beyond acute care. Are there any questions so far? Alicia, do you see any questions?
No, there's no questions so far.
If there are any questions, don't be shy. Okay, so yeah, so what is underlying that approach is that I'm convinced that recovery means recovery measured against the treatment goals of individuals It is, so I think the key point in any treatment, also in mental health care, is that you convince people and you support people in achieving their own goals. It's not about imposing goals, it's about achieving goals. If somebody wants to stay abstinent, then you should support him to become abstinent. If somebody wants to control his substance use, I think you should support that. If somebody wants to address his depression or his trauma history, you should provide that. If somebody is dealing with chronic pain, he needs care with that. So I think a reduced perspective on just the substance use is not allowing you really to achieve the goals our clients have very often or most of the time. And recovery means we need to provide access to these components. So, and I will discuss that with one of the next slides. So we overall also substance use, as all of us know, is a long-term process. It is something which is not managed in a few days or a few weeks. There are some crises you can manage in a few weeks, but I think ongoing support is and the continuum of support is kind of a very, very important thing we are very bad with. And so people have to deal with different individuals, different philosophies, different institutions all the time, and that is pushing them out of the system. Okay, then next is, so the integration is really good. I'm not going too much in detail of that, but this sorry, but this is one of my favorite slides. I think every system in medicine and in production and development, whatever, needs to change and needs to innovate in order to say you need to, in order to function and to improve and to catch up, you need to change things. And the only way to big effects is really disruptive change. That means you need to change the way we are working in a substantial way. So again, that's my core slide. This is the most important slide to understand. If you only have capacity, so imagine yourself, if you only have capacity for, let's say, 10% of the population, which I think is already probably overestimated. If you only have that amount, then the question is, how do you make the best possible use of that? And the best possible use you can make also in terms of access, in terms of continuum of care, in terms of quality, is if you really become selective, who is actually needs to be seen in person, who needs to make good use of online resources, and who should be seen in a video conference, or should be where you could stay in contact over a chat function, over a messaging function, or over email, or whatever you want, whatever the preferred method of communication will be. So with my clients and in our system, it's very often the case that short messages already make it. They are very, very helpful. If you just check in with your clients on a regular basis, every few days, and say, how are you doing? Is there anything I can help you with? Is there anything, shall we talk or whatever? Then you could already stabilize people. You messaging them kind of not only the question, but also I'm here for you. And if there is anything you can so don't underestimate that. That's very important. And the system of web-based resources is kind of really is adding a lot of capacity. So with web-based resources, we can add a full different set of treatment interventions to the mix. So what does it mean? I give you for 3 examples from the risk assessment and management platform. One is, for instance, we have a relatively good tool for assessment and monitoring. If you, you know how lots of discussions and meetings with health professionals go, it's 50% of the time is assessing the situation and documenting. So and then you have probably, if it's good, you have 30 minutes of interaction. If you can do a lot of the assessment before in a standardized tool, and you can come up with that already, if you start a meeting, that would be a time saver. You could talk about the real stuff going on. That's example number one. Example number two, for instance, a lot of people have in the substance use field also have common mental illness like depression, anxiety, trauma, and other things, psychotic things. So if we have modules of treatment which are proven to be effective in big trials with high effect sizes, for instance, for the treatment of anxiety and depression. If you go through, let's say, we call it ICBT, cognitive behavioral therapy, or something like that, you could already intensify the way or the work you are doing across treatment goals and stabilize people in their basic conditions. Third example is we are strong in my group, and I'm as a researcher, I'm a strong believer in strengths-based approaches. So the question is how to train people to address problems, problem-solving therapy. That is a very nice component we are building in RAMP, where people can learn how to structure an approach for addressing the various problems they have. So, and there are far more in that, which are also moving on. So web-based is an addition to what you do face-to-face or in a virtual clinic. So, and the capacity will grow through being able to share the resources to, as a professional, to point you into a specific direction, to catch up and to engage in the system of care.
Michael, there's a question.
Yes, go ahead.
So Hazel and Don are asking, they're saying, I'm familiar with the Stepcare 2.0, which is a model of this kind. Can you send articles on the system of the future or readings? Is there a working group on this in BC or in Canada?
There are ongoing projects, yes. So the Stepcare is even that's more that I would say a more traditional approach, which is established in I think in especially in the Ontario and in other fields. But I would call it more modular care, because it's not it is not stepping up, because in a long-term, from a long-term perspective, it's going back and forth. So for instance, if you move into a crisis, you need a intensive crisis response, regardless what the crisis looks like. Then if you're stabilizing and are feeling better after a period of time, then you may need then more a prevention, stabilization, problem-solving approach. So, and then if things go sideways again, same. So it's not a straightforward way up or way down. It is always an up and down. And so I think we need to have I call it a range of needs and a set of tools. So you need to have the different tools available, and you need to learn to deal with it. And then you can support people in different situations.
Dita asked if Kelty's Key, the BC web platform, would be a web platform of this kind.
Kelty's Key is a good approach, but it's working mainly so as a kind of a prolonged arm of the psychologist. It is not an independent system. I'm more a fan of resources people can use independently of the therapist, but the therapist would especially encourage them, talk to them about problems if there's something, and encourage. So that I think that's a more doable way. If we're not building capacity, if we 100% attach it to the professional, so then we kind of stick in the green bubble. But I want to build the capacity. I want that somebody is waking up at night thinking about his traumatic experience, want to do a self-assessment, wants to go through a module, he can do it or she can do it. So I want to build capacity because I think that's the main thing. Even in the CALTI program, we only have a limited capacity based on the number of psychologists working with that. That would be my short answer. But it's important to be aware that there are some resources like that and the future will bring far more modules. But the concept is important. How to build more capacity, and we are all measured against the health outcome we are producing and we are contributing to. So and that's the point. You want to really engage more people. You want to stabilize more people, and you need to prevent them overdosing. Okay. Okay, then I move on. Okay, so this is my second favorite slide, because it demonstrates my thinking the best. The web-based platform is what I just described. This is the RAMP platform. The virtual substitution clinic would be the place which are connecting you to the OAT treatment, and where your doctor, your nurse, or whatever would be available, and you would add all the components. I talk about that in a second. And then home care means more or less outreach, to treat people where they live. So I think our healthcare system needs to be far more community oriented. Acute care is only a short episode, which is very often not really providing the necessary support to stabilize people for a longer period of time. But anyhow, that would be a big change. I think help needs to happen where people are living. Okay. Any questions so far?
There are no questions, but Deborah wrote that she's using the Breaking Free app in Ontario, which is providing on-demand support.
Yes. I think that's a program also, which is also working with professionals. Is that correct? Where you get counseling and you have to pay for it? Is that correct?
Can I speak?
Yeah.
And do you hear me?
Yes.
There's two options. Ontario government is providing free access to Ontarians right now so you can do it in two ways. You can use it with a clinician and be clinician supported, or folks can sign up for it independently and it's free.
Okay, and is it what are the clients saying about that?
Mixed, like some depending on their access to technology. I think that's creating some challenges, but the independence of it and being able to access it without actually having to go anywhere or utilize a clinician or attend a program is providing some freedom and that sort of on-demand access, which people are appreciating.
Yeah, that's interesting. And I think we should really, I will make sure that in our next conference next year, we will invite people who are kind of evaluating Breaking Free or having experience with Breaking Free, so that we can learn from that. Thank you very much for that hint. Okay, so yeah, describing the concept of the virtual substitution clinic is to have an online platform which is kind of providing a wealth of online resources, which is connecting to the different specialties in medicine. So it needs to, in order to work as a clinic, you need to have these partners on board, but it would be very good for them, because I think that's a really good example for synergy. They could actually, from their, they would save lots of travel time. They would save a lot of costs in terms of infrastructure, and they could give the same advice they would give if you would sit with them in their clinic. And also to bring together the different disciplines, because we know that pain and especially mental health and primary care too nowadays are overwhelmed, and a lot of our clients don't have these services. So if you kind of bring it together through an online system, and user can book an appointment, for instance, through the platform with their nurse, with their pain doctor, with their psychiatrist, in a virtual video conferencing, or just talk to them, pose a question. Very often the things they need are very simple pieces of advice, a second opinion to things. So I think you can cover a lot. You can't cover everything. So for instance, if the housing partner is needed because there is kind of, for instance, the discussion on safe injection, on the public health measures related to the pandemic, or in other things, or mental health care access. So the housing teams are very often a big resource. And also to connect to other health professionals, or if needed, to a toxicology through Life Lab, or a pharmacy where you can get your medication. So it's about connection, and it's also to support and give essential access about the health parameters through essential documentation in the system. Is there any question related to that?
I'm not sure if it's related, but Lisa wrote, I work for the National Overdose Response Service, and we are unable to maintain case management on the line. We are developing an online community hub. In your opinion, what are the key elements to our success here?
I think the key elements, so it's I think, as you mentioned, it's about the capacity. So because I'm sure we won't have any kind of controversy around the importance of counseling and case management and all of that. So the point here is that we need to find ways to really improve capacity. So you need the web-based resources in order to kind of multiply the work a counselor can do. And the role of the counselor would be mainly a crisis manager, and would be to engage clients, for instance, with online treatment options. And so the question, so we have limited resources. We don't have the necessary amount of counselors. We don't have psychotherapists. We don't have the psychiatrists we need and the primary care physician. So the question is, what can we do to make the most effective use of their time? And I would say, if you could do also the primary care advice and counseling through video conferencing, or through any kind of other digital communication, you would save a lot of resources and time, and you can serve more patients. And the same for other professionals working in that field. And you can also, if you run a clinic as part of your housing program or as part of your old program, you can also provide a continuum of care in terms of being able to talk to the same counselor, to the same physician on an ongoing basis. So that is a very short answer. The more detailed answer is really to the discussion, how can we overall build a comprehensive system which has the capacity to serve all the patients we need to serve, which we don't have right now.
One more question by Hazel and Dawn. Is there any connection or work with Together All, which is formerly known as Big White Wall, that is free to Canadians during COVID?
That's kind of this system I'm just describing is open to all kinds of collaboration you want. So my philosophy is it's consumers' choice. I would support any access to services on the platform through if the users really are keen to make good use of that, if they want that kind of service. And I would support more or less every treatment goal they want to pursue. So it's not, so I will work with them on their goals. And if they want a specific, connect to a specific service, I would support to include that service and make it, might I say, part of the toolkit.
I think that's all for now.
Okay. So yeah, if you, this is a different perspective. If you go through the different steps in the process of engaging and work, so you see the engagement of users could happen a lot, especially in the beginning, through the online platform. And it's also, I think, for instance, the housing teams or the O teams or whatever, or any other treatment, in every emergency room, they could say, okay, why don't you look up RAMP and then figure out what your options are? You could explain that in detail. You would save a lot of time and you would make it far easier. So they could register online with the platform or with the program, and they could do assessments, routine assessments. And if, for instance, if in a virtual substitution clinic, the doctor thinks, okay, it would be good to have a toxicology right now because a lot of people don't even know what they're using. So then they could make the link to a lab and there needs to be no collecting urine. So it could all happen in a nearby lab, and they could then share the results, and then they can talk about the results. It would also save a lot of time for everybody. The treatment planning could be done in a systematic way online. The enrollment in different treatments, also in substitution treatment, could happen using online tools and discussing dosing, induction, and maintenance, and then agreeing on a certain way in a clinic or in a pharmacy or whatever, how to dispense the medication. So you could organize so that what is a web-based framework means. And then all the psychosocial supports which are easily available could be provided through the online platform. And if there is a counselor directly available or needed, then you can organize that too. And you can partner here with every agency which is wanting to, could just focusing through on the counseling part. So documentation could happen online, and then the crisis intervention response is a separate one, which I need to discuss in a little bit more detail. Okay, and that's something I'm skipping. The point is, sorry, I would like to go to is how to predict crisis and how to do. So if we want to learn what is the most effective measure, then we need to document how people are doing over time. And that there are models, if we collect over a longer period of time the right data, then we can predict the risk of overdose, we can predict the risk of relapse, and we can predict, for instance, suicide attempts. This is what we are working on right now. This is our goal. And the way to develop it is that we need good data sources to do that based on existing literature. And we need to collect data in a way so that they are really meaningful. And then we're building models based on that and can predict suicide attempts. And that's what we want to build into a risk assessment and management platform in the future. And we hope that will be kind of end of this year will be at least a version of that available, but we want to go beyond that. So for instance, suicide prediction is important because we know that at least 10-15% of all overdose cases are suicidal in nature. Okay, I think I leave it at that and stop sharing so that we can have a more general discussion, and I'm not annoying you too much with more slides. Okay. Okay. Yeah. Open. So discussion. Open to you. What's your feedback? What do you think? Is that something you would like to buy into, or are you skeptical, or what are the questions from you? Alicia, it's your job.
No, I think Jing Liang is raising her hand, so you can.
Yeah, Jing.
Thank you, Michael. I really enjoy your talk, and I think this is really exciting. And basically, you're talking about like this holistic care, this continued connection, and then kind of apply the technology innovation. I'm just, like, I'll just give you an example, and I'm just trying to wrap my head and see how this is going to work, because I felt like this is not just like a project, like it just sounded to me like a movement or mission. So I work with CMHA Health Center, and then even like within this agency that we have, like, say, for example, because you're talking about the pain management, trauma therapy and all that. So we have like MP from VON Pain Clinic kind of seeing our patient. And our challenge is like, the communication, right? Like we have different like EMR system. So really like we can't even see like the MP's assessment in our PS suite and all that. So I'm just wondering, like, with all this great works you guys have been doing, I mean, like, I'm guessing you have the funding from the province and also from, Health Canada or, the stakeholders and all that. So I know there is like a really big, huge platform called BetterHelp, and it's just like for counseling, and they have like 10,000 therapists, social worker and all that. But this is like, you're paying like $400 plus per month to see a therapist like once a week, that kind of thing. So I'm just wondering, like, with all this, like, that's a lot of like agency organization funding. It sounds like really great, but like, I'm just, trying to see like, how this is going to all work out, and especially with billing and all that, like different agency, different housing, like when you're looking at like the housing and the technology. I have a lot of complex mental health patients, like they don't even have phone or internet access. And also you mentioned a lot of patients, they have like a complex trauma and all that. So I felt like this is kind of like overwhelmingly the whole mental health, not just like substance abuse.
You're correct. But so if you think about even your typical client, right? They're not coming with one complaint. They're not really, they reporting all the different issues where they failed over time. And I think we have, as as people working in the health field, especially in substance use field too, in mental health, we have to start thinking all the whole process from the end. So what is actually our goal with what we are doing? And I think we're getting lost very often in that process. And we then start to become happy, and even if small things are working. And right now, I think if I'm comparing, so I know I do a lot of international work. If I compare healthcare systems, Canada is very complicated, and it's not really that effective. And I think we can do much more with them. And you're correct. So I'm not. So the model can be used commercially, but it can be also used in a public health system. And I want it to be used in a public health system. So my passion is more to build system also for countries with no big healthcare dollars, which are so like with no existing mental health care system, and really to create capacity for for those who don't have any other kind of support. So that said, I think how can we build capacity in the way? And we could, if we organize a clinic or our healthcare system in a clinic like that, or in a way like that, then the MSP could pay for the physician time, and it's up to the health authorities to use the capacity they have for social worker or counselor or nurses, also to make better use of that capacity in an integrated system than letting them running around and having very few patients they can talk to, actually. So we learned a lot during the pandemic. A lot of things worked regardless of the skepticism. So I think it's about you're right, a system like that is a paradigm shift. It's not about just adding video conferencing to the mix. It's adding, let's say, the big bulk is the online capacity, online resources, and then to link in also peer mentors or adding other people who are willing to support our clients into the mix and connecting them to them. So it's really a different way of organizing care. You're correct with that.
Along those lines, Deborah asked on Huba, like, I'm curious about whether folks are thinking about hybrid options, like combo in-person and virtual group therapy.
I think that's perfectly fine. Have you probably heard of a virtual reality platform called Second Life? I don't know. Anybody heard of that? That is, for instance, you can have online group therapies in Second Life, and you can organize as kind of, you can do this kind of in an interesting way. It's kind of it's a hybrid model, actually. So you can do this. But so we are very early days in how to make better use of all these options. And I'm all for, we should try what is the best, acceptable, most effective way to support our clients. That's my guiding question, actually. Yeah, Aiden, go ahead.
Hello. See, I have a question mostly involving like engagement. Like, how do we get people to sort of participate in these programs? There's also there's the client side to that. Like, how do we get clients to engage with these programs? Because while there's certain, well, I see sort of online and like virtual solutions as definitely being more convenient. I also feel like they'd be easier to like blow off, just from sort of my experience, you know, motivation and like sort of wanting to attend. I work with people with dealing with substance abuse and youth and stuff, and it's in sort of community homes, and a lot of sort of time is spent encouraging and like motivating people to go out and like attend, you know, meetings or therapies or things like that. And so with sort of this online virtual space, like, how do we get people to want to attend them? Is it something that we'd have to work, like we'd have people in like community homes would have to sort of buy into as well to like encourage clients and stuff to participate in, or other sort of youth groups that like assist people in these circumstances, or is there something about the program itself that you think would be motivating for a lot of people to engage with?
Yeah, that's thank you very much. It's a critical question, but it's not a critical question only for online. It's a critical question for all treatment programs. So if you think about the low retention rate in substitution treatment or treatment we have in Canada, so about 30% or so in the first year. So 2/3 are leaving the programs because they're dissatisfied. Then we obviously have an engagement problem across the board. So also with other detox, 50% probably of patients leaving against medical advice. So yes, engagement needs a lot of attention, and that is a lot of our work in programming, developing a platform. For instance, second, how to increase engagement. I think if you think about computer games, how the kids are responding to computer games, how parents getting nervous, okay, they playing again, and then you negotiating half hours, you allowed, if you're behaving well, half an hour of they are just kind of totally fascinated by that. So the question is how we learn from those very successful engagers for our treatment purposes. And what we are kind of trying to develop is a gamification approach for treatment programs. So, and for instance, positive reinforcement. Instead of telling them what they can't do all the time, telling them, okay, encouraging them, engaging with them, say, look, giving them good reasons to do stuff instead of yelling at them all the time and throwing pieces of advice they don't want to hear. So engagement is a critical question. And I think online resources, including games, including relationship building and whatever, are the key to better engagement. So that is the short answer. How to do that? It's complicated. I think we need to relearn that too. We need to learn from our clients in order to really to be more successful. We need to listen to them and then using their wisdom to build more engaging systems. And actually also any good psychotherapy, if I would sit across somebody, would be driven by my efforts to engage them. 50% of the work doing there would be engagement and make it meaningful for them so that they really feel understood and feel encouraged and would feel better after talking to me or to you.
Yeah, so thank you. I think that's a really good approach. I mean, I guess the note too about like computer games and stuff is something I've been thinking about as well, because I mean, they're very engaging, and I guess using some of these strategies that in the commercial sphere have been used to retain like consistent engagement in certain programs, using in a therapeutic setting is a really good tack. And perhaps an online, I guess there's some ways an online or virtual space could be more engaging than a personal space for some people as well.
Yes, I agree. Yeah. So Alicia, I think we are close to our finish line. Is that correct?
Yeah, I think we have 1 more minute actually.
Okay, then let me use the 1 more minute to thank for a very very engaged discussion. I really appreciated that we were able here to come together really in a very broad and a group from different angles of the country. And I hope that we will continue this conversation in one way or the other and be able to collectively turn around the big tanker. Thank you very much and enjoy the rest of the conference.
Thank you for coming.
Bye.